Next presenter.
So next, Dr. Gautam Singal has joined.
So yes, sir. Also nothing to do much, sir. No complicated, nothing, no complicated stuff, no bifurcation, no calcium, nothing as such. Just a simple PCI, but the circumstances would let us to such a PCI. So this 56 years old lady with the previously no known comorbidities and had an acute onset of chest pain for 2 hours prior to admission in an outside hospital. Ours is a sir, hub and spoke center for STEMI, which patients get thrombolized, they do come to us. So she presented outside and sorry, yeah. So this was the ECGS presentation in the hospital, which was sent to us, and they said whether they could thrombolize. We said you can go ahead, and she was thrombolized, and immediate she was thrombolized with connective place, and she had immediate symptomatic relief, no immediate complication, and ECG post thrombolysis had shown near complete resolution. And then she was referred to us for further management. On presentation to us, she was conscious, rendered, absolutely pain-free, hemodynamically stable. There was no mechanical complications post thrombolysis. And she had a BP of 110 by 60, heart rate of 84, saturation of 96% of room air, no signs of failure, chest was absolutely clear, sir. This was a ECG post thrombolysis and on a presentation to our hospital. So we said that she came to us on Sunday that she's absolutely stable. So we take her up on an angiogram tomorrow and see the status of the vessel. But that was a echo screening which we done on an emergency, which is hypokinesia of left anterior descending artery with an EF of 30% with no mechanical complications, no MR, no VSR, nothing as such, no pericardial lesions. So that's a echo. So LVs, on dimensions are okay, no LV dilatation, nothing as such. So day two, before we could start our day at around 7 a.m. in the Monday morning, she had an hemodynamic collapse. And she had recurrent VT, but the morphology of VT was monomorphic. There was no polymorphic VT. It was not even, the initiation we could look at it. It was not even initiated by a VPC or anything. And a monomorphic cause of VT, recurrent VT, incessant VT. So electrolytes immediately, ABG% electrolytes were normal. That was the ECG of VT, sir, which we could record. We can clearly see it's a monomorphic VT. So we started on thought to be ischemic, though it was monomorphic, xylocard infusion, medon bolus infusion, metabolol bolus. She was in fact cardioverted multiple times. Even we tried, double DC shock. We just put in two pads and two paddles to try to give sequential DC shock or even synchronized shock of both with all the four paddles. But she just transiently used to come to sinus rhythm and then again go back to VT. Intermittent sinus rhythm, whichever we could record the ECG, unfortunately we don't have. There was no STED elevation or which was suggestive of V infarction. So she had an hemodynamic collapse, started on inotropic support, IABP was inserted considering ischemia, and did not have any response. So TPIs were inserted. We tried to do an overdrive pacing in that patient. Even then, she did not. And the VT was just insufficient. She just was not responding to any treatment. So she was sedated, electively intubated. We thought probably, sympathetic drive should come down and probably, her VT should settle down, but nothing was helping. VT persisted. So we gave a stellate ganglion block. We just gave only unilateral with the, we thought if we give a bilateral, probably she may go into bradycardia and CHP, though we had, TPI with us, but we thought we probably would just try to do a unilateral stellate ganglion block and there was still no response. That was X-ray on the bedside. The IABP can be seen, the TPA lead can be seen, and gradually it worsened to this. She went back, pulmonary edema, despite being intubated, saturation around 90. So we were at our wits and what to do, back to the wall situation we had. So what are our options? Patient had recurrent monomorphic VT, hemodynamic unstable, BP of 80, systolic with augmentation of 90, saturation of 92, 93, despite on mechanical ventilation. So should we consider Impella in this patient? So one, it was not available on shelf. Two, it is expensive and not a long-term solution. Third, our possibility was since she had a monomorphic VT, there was no ECG was not suggestive of any reinfarction. There was no DST elevation. So we thought, what if we do an angio and it happens to be a recanalized vessel? It is just all just a irritable myocardium which is leading to the VT. So what is Impella? How will it help us? So we thought against Impella, and then we discussed the patient attendance. The other option which we have is we put her on VA ECMO support, and the VT, surprisingly, the VT gradually slowed down. It became intermittent, then to normal sinus rhythm, intermittent bradycardia, probably because of the drugs. that she had on Xylocard, metoprolol, and she was on amidon infusion. So she had the transient temporary pacemaker dependence. Gradually, she returned to sinus rhythm with no dependence on the pacemaker. Hemodynamics started gradually improving. Blood gases started improving. Lactates, which were 15, had come down to 7. So all this happened 20 minutes post ECMO. So then, we decided to take her up for an angiogram, and let's see and what the anatomy holds for us, and probably do a PTC if it's required, depending on the anatomy what the angiogram shows us. So when we can see when we took her up, heart is hardly contracting, and there's a proximal LED tight lesion with a hardly TIMI 0 to 1 flow. So immediately we wired the vessel, we balloon dilated, and there was some flow was restored. And you can see the angio, there's some conductivity, though probably, in retrospect, we see that there's slight improvement, but still remains the same. So we took a 3.5, I guess it was 22 stent, which was, immediately, dilated, no post dilatation was done. So the flow was better. So then we thought, okay, since we are there, take a RCA diagnostic. We never expected the RCA to have a significant lesion. But the RCA made the RCA showed a tight 90% lesion, and we immediately changed it to the guide, and we wired the RCA. Though culprit shock, says that only, infarcted vessel has to be done in shock, this thing. But we thought that the patient is on VA ECMO, patient has a recurrent VT. If we do not do this, we may not get another chance. So we just went ahead and tried to do the PPC of the RCA. We directly stented the RCA. We could see there is a slight indentation in the stent in the middle part, so obviously not fully dilated. It was a 3.518, so we dilated with 3.75 of 4 balloon, and that was the result. This was the final result of the RCA. Post balloon dilatation. That was the ECG post PTCA to the LED and the RCA. And so hemodynamics started getting better, had a spike of fever in the evening. Antibiotics were continued. And since she was not on TPA dependence, so we removed the TPA. We just wanted to deline her as much as possible so that, the all sources of infection could be, handled immediately, or probably, in due course of time. So patient was weaned off from the VA ECMO the very next day. She was extubated the third day, and IUPP was removed on the fourth day. Review 2D echo post, removal of prior to removal of IUPP and post removal of ECMO showed the RWMA, but EF had improved from 30 to 40% with mild MR. So her fever gradually subsided. Pulses on left lower limb was, feeble, but limb was warm. There was mild neurological deficit in the form of a foot drop, which, persisted. She was started on physiotherapy. She remained with us for 7 days, and she was discharged home on the seventh day. There was a mild foot drop injury, but, she was ambulatory with support. And she had mild foot drop on follow-up. There's a residual drop, but there's a significant improvement in the foot drop. EF has improved to 45 to 48%. She's NYHA. I would not say 1 because she's still ambulatory with support. So she's somewhere between 1 to 2 with no resting pain, no further episodes of VT. Our ECG remains the same. We have done a Holter on her also. We're on a 48-hour Holter, which shows not even a VPC. She is on dual antiplatelets on Brilinta and aspirin and beta blockers and low dose of ACE inhibitors. So she remains to be NYHA class 1, no further VTs. There is a debate going on because she had a monomorphic VT, but there was no scar on echo. We've done an echo again. There was no meaning to do an MRI or not, whether what was the cause of this monomorphic VT, but we just, keeping our fingers crossed and then just waiting and watching if there's anything else. That's also not.
Thank you. Thanks, Gautam. It was a wonderful case, I would say, and quite a learning from it. So I think let Rupesh first have his let's have his inputs. What's the learning? Let's okay, this happened. This happened and it happens. I think we
Sir.
had so many patients of MI where they suddenly become hemodynamically compromised and then ventricular arrhythmias happen. But what's the learning? Rupesh?
I mean, it's a terrific case, sir. A lot of learning. I mean, I do agree with him. It was a monomorphic VT, but given the history, I would, I mean, not be so fixated upon treating it as non-ischemic and giving ganglion blocks and ECMO. Probably once she collapsed, I would have definitely intubated, put in an IVP, and take her up for the PCI probably earlier before trying this ganglion blocks and stuff. I mean, theoretically, it does make sense. It's probably, I mean, we expect it to be polymorphic, But then there might be some small substrates which can cause this pattern, and uh, ischemia actually was the predisposing factor. So it was not just the ECMO that reverted VT, but it was the revascularization ultimately which probably brought the patient out.
I think yes.
So
The Rupesh's statement is quite emphatic, and I think even Gautam, is also trying to point the same statement that, I think monomorphic versus polymorphic, that's a old school of thought,
Sure.
ischemic versus non-ischemic. I agree monomorphic, but then we have seen many patients like this, where it's monomorphic, but then ischemia is triggering monomorphic. So
Sure.
it's not purely ischemic polymorphic type VT, but so that the lines of monomorphic, whether ischemic or non-ischemic, they are blur. There is a
Right.
blurring in that direction. We should not base our decision that it is totally a scar VT. And in fact, if even if it is a scar VT, that scar VT is getting unstable because of some reason. And that on the periphery of the scar, you mentioned there was no scar in the end, but I
Right.
am saying a hypothetical situation. A
Right.
scar VT, if the ischemia is happening on the periphery where the electrical conduction is getting chaotic because of some reason, and I think so the learning here is, if patient deteriorates, now you hadn't checked the coronary angio to start with, patient was thrombolized. If the patient has deteriorated and throwing a lot of VT, intubate, IBP, and check angio before really thinking of ECMO and other stuff. And probably we could have saved ECMO, but that's okay. That's okay. You finally have saved the patient. That is the key.
So
Whichever
the
way.
plan was there. So we never thought it was not an ischemic VT, because we knew we had a substrat, and we always thought that if it's an irritable myocardium, that if you have a single exit from a differential, even irritable myocardium, you still may have a monomorphic VT even in an ischemic myocardium, because the exit remains the same. So the VT morphology depends on the exit of the exit point of the VT. But the point is that she sort of escalated so fast. Whatever we were doing, and that time she had only BP of 80 with severe metabolic lactic acidosis with lactates of 15 to 17 and pH of around 6.9. And relatives were a bit reluctant, so we thought probably we would take her up, and what if she collapses? So we thought we'll do whatever we can, and just unload the ventricle somehow and give
No,
ventricle
no.
a bit of rest.
So this
No,
point
no,
well taken. So we are not
right,
debating that issue.
yeah,
I think putting a VA ECMO, VA. So this is the objective of this session, that we are
right,
seeing that mechanical circulatory support is in sick patients is will give us more salvage of these patients. The salvage numbers would increase. We can get more patients out of the crisis if we are using the mechanical circulatory system. Similarly,
right,
the impella,
right.
that's a debate. VA ECMO versus impella is lot of debate. But anyway, I think your direction was very good. Patient suddenly deteriorated. You went in for a mechanical circulatory support, and then and that also gave you a leverage later on with the
We were,
angiogram and the
yes,
revascularization.
right.
So maybe at that point, if you wouldn't have used that, in that
yeah,
circumstances where VT is happening, the lactates are 15, and opening the vessel may deteriorate the patient further, and patient may not come out of that vicious cycle. So I
Right.
think that point is well taken. But the message is, do not rest ourselves with a monomorphic VT. I think our threshold for checking
Yes.
angiogram should be very, very low, and we should do it quickly if the patient is deteriorating. Even if we have done a primary PCI, it may be a thrombus of the stent again.
Absolutely. That's why I wanted to show this case of monomorphic VTs are not necessarily, are always scar VT. And it
No,
was too early for
absolutely.
a
This
scar
is this is
formation.
this is
Yes.
very good, Gautam. This is very good. This gives us
Right.
a very good learning, and
Right.
small learnings are important in saving the patients. Thank
Thank you,
you.
sir.
Thanks for
Thank you, sir.
bringing the very important case.